Okay. Good evening, everyone. Am I audible to all?
Absolutely.
Okay, thank you. First of all, hope you all are fine by the grace of Almighty. Now, since the end of 2019, we have experienced an invasion of microscopic UFO, okay, into our planet Earth, and leading all of us into a pandemic illness. Now, you all know that the culprit very well. It's nothing other than COVID-19 SARS-2. I'm Dr. Goutam, MD Pathology, now working at Deficiencies Government Medical College and Hospital as demonstrator. Okay. My special gratitude and special thanks to Mitra and Company Private Limited, which is now one of the leading brand in diagnostics, for arranging a scientific webinar in this tough time, and of course, in a tough topic and controversial topic too, that is vitamin deficiencies, diagnostic challenges, and its significance nowadays. Of course, now on the webinar, yes, it's an atomic explosion. Please don't sneeze in air. Now, first of all, I would just like to highlight about the mechanism of SARS. Okay, it just gained entry through aerosol droplet fomites. The size may differ and name and different, but the dangerousness is equal. So it first affects the innate immune system, that is dendritic cell activation and uptake of viral antigens of them. Then after that, adaptive immunity takes over, and all the things like cytokine production, T cell differentiation, cytotoxic T cell mediated damage, B cell mediated antibody production, all these occurs. And few are unfortunate can't take over this, and unfortunately they died. So we can now say that the immune system is the major part of COVID-19. If a strong person gets infected, it is cleared automatically, and after 14 days, he is absolutely okay. But those whose immune system is a little bit depressed, those are the sufferers. Now, here is the same mechanism that the why cytokine storms occurs, and ultimately the patient died of severe lung injury that is called acute respiratory distress syndrome. Now it's time to assess the vitamin status, and there are many vitamins and micronutrients which upregulates, rather regulates our immune system. Now, there are many vitamins and micronutrients which helps to boost our immunity. But today, due to shortage of time and of course restriction, I will discuss about 3 major vitamins which were prescribed in last 1.5 years, more than 1.5 years for every patient. And those vitamins are nothing but vitamin D, vitamin C, and vitamin B12. Okay, now it's time for vitamin D. It's available everywhere, from sunlight to vitamin sachets and tablets. But the key thing is the sunlight. Next, how it's produced. Now, vitamin D is produced from sunlight, mainly D3 part is produced from skin. It's from dehydrocholesterol, then to vitamin D3, and in liver it hydroxylated, forming 25 hydroxyvitamin D. Again it goes to kidney, again hydroxylated 125 dihydroxycalcitriol. The major portion of vitamin D in our body is vitamin D, 25 hydroxyvitamin D. But the potent form is 125 dihydroxyvitamin D. Now, how vitamin D helps in our immune system regulation? Vitamin D helps in many systems, like it differentiates T cell into T cell 1 and T lymphocytes in 1 and 17, which regulates our immune system. And at the same time, it T cell regulator receptor upregulation is done by vitamin D. So it helps in our immune system very much. It is directly affects into the lung and reduces lung injury due to angiotensin converting enzyme inhibition and ACE2 receptor upregulation. So if we have enough vitamin D, we can somehow prevent our lung damage. Now, what are the types of vitamin D? Vitamin D1, vitamin D2, we actually get it from plants. Vitamin D3, that is the major vitamin today's of discussion, vitamin D4 and D5. Now, vitamin D is a pro-hormone which comes in two forms, vitamin D2, that is argocalciferol, and vitamin D3, that is cholecalciferol. Argocalciferol found in plants, and cholecalciferol, which is found in animal-based food. As we discussed earlier, synthesized from ultraviolet B, from 7-hydroxycholesterol in skin, from there to liver, 25 hydroxyvitamin D, from there to kidney, 125 dihydroxyvitamin D. The 25 hydroxyvitamin D is the major circulating vitamin, and it's bound to vitamin D binding protein, and its half-life is 15 days. On the contrary, 125 dihydroxyvitamin D is half-life is just measures in hours. So the only way to estimate vitamin D is the serum concentration or plasma concentration of 25 hydroxyvitamin D is the only way. Now, there is a study which clearly shows that in few patients who are suffering from COVID, they are either deficient or they have insufficient vitamin D. Now the challenges. Yes, we have in estimation of vitamin D. Now diagnostic challenges from clinical deficiency side. First of all, the signs are only in that case where there is severe and specific deficiency of vitamin D. At that case, the signs are evident. The vitamin D requirement and vitamin D intake and vitamin D status differs with age, sex, and of course in pregnancy. Now, what are the signs of that? In children, its most common vitamin D deficiency form is rickets, that is bow leg. which are very much rare now. We can't see patient with bow leg or card legs. So it's difficult from clinical science. And in adult, it's manifested as low back pain and osteomalacia, which can occur in calcium deficiency, which can occur in age-related factors. So there is no specific science of vitamin D that we can assume that from that vitamin D deficiency may occur. So it's now came that the methods or the biochemical methods of vitamin D estimation. It is the history at first time when there was only two methods of physiochemical and bioassay. The physiochemical method is very much time consuming due to the separation procedure for eliminating the interfering compounds like retinol, cholesterol for this. So then we shifted to bioassay. It has also very much low sensitivity. It takes more time and the costing is also very high. Then we shifted to competitive protein binding assays. Here again, time is the main factor. We used beta lipoprotein as the carrier molecule, and we have to extract it from human plasma, and several days is taken to require the equilibrium and displacement and proper binding. So it's also very cumbersome. Now the updated technologies came. There are immunoassays like RIA, CLIA, EIA, etc. Now here what happens, antibody is co-specific for vitamin 25 hydroxy D3 and 25 hydroxy D2, but it could not detect the 3 epimer of 25 hydroxy vitamin D. So it is a lag of this assays. After that come direct electrochemiluminescence immunoassay. After that came chemiluminescence microparticle immunoassay. This is the most updated form of immunoassay. Now here are some study that we already done in different machines, and we estimated vitamin D. And we have seen that there are not a specific benchmark that this is the result and this is absolutely perfect. So there are a few studies I have quoted from the study previously, and it's all are in the renowned journals like Science Direct, JAMA, like also. You can see that in various, you just exclude HPLC right now, immunodiagnostic system method, RIA, EIA, advantage, license 1, 2, RESIS, all this, there is a slight difference of vitamin D levels during estimation. Same things happen, and there is a passing backlog regression analysis done in the next study, study 2. In case of low pool, the result is same, there is difference. Again, one study, this is a renowned study. Okay, now we all have came to a that it's difficult to estimate vitamin D, and for surety that this is the 100% right result. Okay, now again we are quite smart enough and we accepted the challenge, and an evolution of our high profile liquid chromatography. It is the gold standard method, most accurate and reliable method. HPLC method is able to separate and quantitate 25-hydroxy D2 and D3 both. Now after that, when it is mixed with tandem mass spectrometry, it's a wonder. Of course, yes, Mitra and company has successfully accepted the the challenge and improvised their ELISA and EIF kit for estimation of vitamin D with high sensitivity specificity. Now we come to vitamin C. Vitamin C is present in many things, and of course as chewable form, which we all chew it in last more than 1.5 years. So the major origin is lemon, tomatoes, green and red chilies, strawberries, guava, papaya, all of this. Vitamin C has also effect on our immunity, both innate and adaptive. In innate immunity, it causes macrophage mediated virus killing, and of course neutrophil chemotaxis, which ultimately releases cytokines and controls the infection. It also helps in adaptive immunity, like B cell mediated antibody production and T cell differentiation for control and to restrict the disease process. Now, diagnosis from clinical deficiency signs. We directly came to vitamin C deficiency challenges. It is more hard to diagnose a vitamin C deficient child. A child present with arthralgia, myalgia, it may be a growth pain. And if scurvy occurred, then it's evident on bone X-ray. Then bones what do we get is sparse line and the articular disc degeneration. There's all are rare and can be misdiagnosed like all other disease. It can mimic as tuberculosis of knee, tuberculosis of other joint. So it's very cumbersome. Diagnosis clinical deficiency sign, vitamin C deficiency. In adult, again scurvy, skin, gum, heart failure, these all are non-specific. So from clinical deficiency sign, we can't handle the vitamin C deficiency status. Now there are some pre-analytical challenges. What are those? Vitamin C has several measurements. It has formed ascorbic acid. It has formed ascorbic acid and its oxidized form, dihydroascorbic acid, and total. Now what to measure? We have to measure either ascorbic acid and in oxidized form or total vitamin C. So it is a great disadvantage for that to become multiple form, to have multiple forms, isn't it? Again, there are some pre-analytical challenges like patient status, fasting causes deficiency, false deficient, smoking, false deficient. In case of iron supplement, it may causes false deficient. If next the second part is sample integrity. If the hemolysis occur, it may be intravascular within patient body, or it may be during the after collection. If hemolysis occur, then what occurs? There is release of free hemoglobin, which reduces vitamin C. So we can't getting the actual level. Now we have to handle the sample again in from various parameters like photosensitivity, pH, temperature. So it's very difficult to handle a sample of vitamin C for actual measurement. Now the most common form of vitamin C is seen in plasma, but the fact is it has a dramatic rapid rise and fall. If one takes vitamin C, the level rise rapidly. And when depletion occurs, it falls rapidly. But the good thing is it's easy to measure. We have another vitamin C pool in our leukocytes, which has less dramatic rise and fall. But the disadvantage is that we need a very large sample volume to extract the vitamin C from leukocytes. And again, the bad thing is the platelet contaminant. It will falsely decrease the vitamin C level when we measure from the tissue. So there are many pre-analytical disadvantages. Now, anticoagulant, we have to use K3-EDTA. Rather, K2-EDTA site rate are good, but K3-EDTA is the best. Now, its time you get a very short time. It's very unstable. Separation should done immediately and immediately stored at ultra low temperature. If we are late in doing the test, that's very cumbersome. Now, there are some studies where there is difference between smokers and non-smokers. We have given there is heavyweight, underweight, even in case of sex, men, women. This study proves that there are differences. Now, the actual diagnosis from biochemical analysis. Now, there are three major biochemical processes. There is enzymatic, there is spectrophotometric, and the gold standard method is HPLC, like vitamin D. So the next slide, I would like to highlight that this is a study which is done in various methods. And we can see that the level of low vitamin C average is different in various methods. So in case of vitamin C also, it is very cumbersome to assess the level. Thank God we have HPLC, the only direct detection method that we can assess the vitamin C if the sample is properly stored, then only. Next, I should go to vitamin B12, with the sources of vitamin B12. It is present in mainly animal foods like fish, egg, meat, and of course in tablet. Now, the function of vitamin C, vitamin B12 as immunity. Vitamin B12 helps in B cell and T cell differentiation. In T cell differentiation, again, it helps in inflammation and, of course, to control the inflammation. And after induction of B cell, it produces immune antibody too. And in the systemic mechanism, vitamin B12 it reduces the cytokine storm, especially interleukin 6, 10, 1, TNF alpha, and it reduces the hypercoagulability state. Now, diagnosis from clinical deficiency signs. Here again, there are the diagnostic challenges that we should start from the clinical deficiency chart. In child or young, the symptom of vitamin deficiency is megaloblastic anemia. Now, the signs and symptoms are like anemia. in the child there are thalassemia, there are iron deficiency anemia. So there are many other causes of anemia too. So we can't assess vitamin B12 deficiency just seeing low hemoglobin. In adult, it again causes megaloblastic anemia, which is non-specific. Spinal cord changes, that may changes. Of course, in old age, there are other causes like age-related changes, like spondylosis and neuropathy. Of course, there are other causes, diabetic spondylosis. So there are no definite signs that we can diagnose from deficiency signs that, oh, this is vitamin B12 deficiency. Now there are pre-analytical challenges like reference range dilemma. The reference range is differ from age, from child to old age, from dietary intake, vegetarian to non-vegetarian, and of course malabsorption. There are other diseases which causes malabsorption. So it is a great disadvantage of this. And other challenges like there are associated marker like methyl methyloric acid and homocysteine. But these are also increased in others diseases too. So these co-markers are also not reliable. Now, coming to diagnosis from biochemical indices. This first, it was done by microbiology detection by culture inside bacteria. Next, that is immunoassay, ELISA, which is again added by radioactive form, that is by using cobalt 57. There is direct detection method, HPLC. There is capillary electrophoresis method, radioisotope and mass spectrometry method, optical detection technique, chemiluminescence, absorption and fluorescence technique, surface plasmon resonance, Raman spectroscopy. There are a lot of methods or principles by which we can estimate vitamin B12. But there are difference in result. So I have put it from two studies only, where I compared chemiluminescence, fluorescence quenching, surface plasmon and Raman spectroscopy. These all are good and reliable, but there are advantages and disadvantages. In chemiluminescence, it is fast and sensitive, but the specificity is very poor. In case of fluorescence technique, it is fast and sensitive, but specificity is again poor. Surface plasmon resonance, there is advantages, kinetic information is good, but specificity is poor and sensitivity is low. Raman spectroscopy, the specificity is poor, specificity is good, but the sensitivity is low. So there are disadvantages. Now I would like to conclude some complications of interpretations and research challenges. These are applicable for all the vitamins I have discussed. Like most plasma or serum vitamins, these are affected by infection, inflammation, and due to presence of other acute phase reactants like ferritin, like CRP, C-reactive protein, these are. So in that case, we have to exclude those conditions after the estimation of plasma level of CRP, ferritin, and anti-chymotrypsin disorder. This can affect by dietary intake and vary with seasonal intake change. I have discussed already earlier. So we have to be cautious about the sample, and it should measure intervals at regular intervals. Now, the results may vary with different assay for same analyte and between laboratories. So we have to first avoid direct comparison between the data set of different laboratories. Rather, we should use the quality control material and quality assurance schemes available. There are quality control schemes available. We know just for vitamin C especially, but it's for all. Several vitamins exist in multiple forms. We have seen in case of vitamin D and vitamin C. So we have to be particular to measure either all the relevant forms separately or the most important form by which we can give a image to the clinician that he or she is deficient. Now in samples, some are protein bound, some are liable to heat, light. We have seen in case of vitamin C. So in that case, we have to separate it from it and store in good places and appropriate places. So now it's time to get all our vaccines. And finally, thank you.
Thank you, Dr. Goutam. There, it was really what you can say. I would rather put it this way: like it has been inspiring and it's stress-free. You have made it so kind effort in relieving our stress through this presentation that we almost forgot that we are actually in the middle of this challenge. So there are a couple of questions which are definitely lined up for you. So just hold on.
Okay.
The very first question is, since we are already living in a country where we do have lifestyles in every pocket of the country, and there are multiple complications when it comes to lifestyle habitats and food intake. Now, people are asking that with the prevailing situations, what we already had pre-COVID, what kind of implications are new to this particular scenario? I presume they must be expecting an answer like how do you assess the gravity of the situation in a pre-COVID versus post-COVID scenario as far as vitamin deficiencies are concerned?
First of all, I would like to say that in the pre-COVID situation, we are not worried about our immunity. And at that time, the total, I have gone through some papers that the estimation of vitamins and other micronutrients which are required for our immunity is prescribing pre-COVID and post-COVID, it's more than 5,000 times higher. Okay, the scenario is before pre-COVID, we all have the vitamin deficiencies, but we doesn't acquire the COVID. After the COVID, it actually measuring very much parameter. We have seen that the vitamins are important not only for our healthiness, but also to prevent some disease, which we could rather restrict, or we could be able to get early recovery if we have the vitamins adequately in our health. And regarding the diagnostic part, it's hugely expanded. And before pre-COVID era, no one is actually worried about the process, the procedure, so much of the actual vitamin deficiency. But during and after COVID period, it's it's another study lined up regarding the vitamin deficiencies and how we assess the vitamin deficiencies, and the actual 100% gold standard methods all are.
Dr. D, the very next question, what people are asking is like, already we are in a country which is probably having the second rank in terms of diabetes. And we do have comorbidities with respect to lifestyle habitat and diabetes, which is well evident, which is well documented also. Now, there has been evidence that in the second wave, when the Delta strain had struck, most of the diabetic patients have been found to have comorbidities after that particular recovery phase. Okay. Now, where does if a person has been diagnosed with vitamin deficiencies in these kind of strata, what are the diagnostic approaches one should take, and what are the challenges as a clinical fraternity? How would you address these challenges?
Now, the fact is, diabetes, whether it is type 1 or type 2, in this question, the type is type 2. Okay, so the diabetes itself is the major hypoimmunogenic disease. If one is diabetic for more than 5 years, then his immunity status is very much low. So after there are, okay, I will like to add, as I have worked in such type of hospital for since last 8 months. Okay, I would like to add that even when that a data came that yes, a dose of steroid will decrease the mortality, but we all know that the steroid of course increases our sugar level, and about 1 out of 10 patients is diagnosed diabetic at that time. So we have to exclude whether the increased sugar level is for diabetes or increased sugar level for temporary steroid injection or tablet. So if it's diabetic, then all the parameters which are required for the status of immunity as well as post-COVID changes like D-dimer, ferritin, LDH. LDH, of course, denotes the lung damage, amount of lung damage. So our approach should be every 2 months or 3 months, we should go through our sugar level. Every 3 months, we should go through HbA1c level. We should get actual treatment, and we should do the other supportive investigations regularly, like for renal, it's urea creatinine, and of course, the other issue, if one's get any type of complications like chest discomfort or others, he should immediately go to laboratory for a D-dimer test. We should do exercise regularly. We should change our eating habit, yoga, and others. And hopefully, this all will keep us alive and healthy.
There is no doubt in all these things, Dr. Day. One critical question the participant has asked is, it has been observed that in the post-COVID scenario, we have had what you can say outbreaks of mucormycosis. We had outbreak of herpes simplex virus. We had outbreak of bone death also. And there has been few incidences where diabetic patients and people with too many deficiencies, I think that is with respect to obviously with immunity, have passed away. That has been what the fatality count has increased even after recovery. Now, I would just like to know from your end, which particular age group or strata would you put up in the vulnerable group as far as vitamin deficiencies are concerned in this particular scenario? And what would be the impact between a vaccinated as well as a non-vaccinated person in this kind of a time?
Okay. The first question is that what is the actual age of the diseased person who are died or in low immunity level? So there is actually no age. We all know that old age after 60, we all are with low immunity. We all will become with low immunity because our all system will exhaust after a 60 years of journey. So the first of all is age. Any higher age is vulnerable due to low immunity. Next is the most common and most deadly thing is, of course, diabetes. If it is type 1 diabetes mellitus, then it's juvenile onset. It can occur as age group 13 to 18. And if it's type 2, then it can occur at somehow between 40 to 60. Next is, it's our burden that a subcontinental country within residing in a subcontinental country, that is tuberculosis. Tuberculosis affecting lung, COVID affecting lung, mucormycosis affecting lung. So we have to early diagnose and treat the COVID, the tuberculosis patient. Next, there is other categories like who are regularly getting the anti-metabolite drug, who regularly getting the chemotherapy, who regularly getting the radiotherapy. At any age group, they are vulnerable for low immunity. Next, the second question was
with respect to
please,
the vaccinated and non-vaccinated people, how would you address that challenge?
now about the vaccination. Now, we all learn from the second wave that vaccine somehow prevents the severe disease. We have learned already. And being a in charge of a COVID hospital at Purulia Medical College, I have the data that the death rate was high in the second wave, but at the same time, the death rate was about 99.9% was unvaccinated. So, unvaccinated, those who are not vaccinated. So the vaccination is most important in this case, as it's viral, it's very much explosively affecting all the people. So we have to get at least the herd immunity of the basic strains, at least the herd immunity of the basic strains. Now our government has completed near about 40 crore vaccination. So it's a good news, and hopefully what will occur in the third wave, we will manage it with quite efficiently.
Definitely, Dr. Day, I think people are definitely queuing up to the vaccination centers as we speak, and nevertheless, they are increasing. One last question to you, Dr. Day, before we wrap up, is that what is the future with respect to deficiencies and the comorbidities which you have highlighted? Whether they will be much more aggravated or whether it should, what you can say, come down with respect to vaccination. What I think people are asking is that with respect to the susceptibility to more variants, deadly variants, we do not know whether the new third wave will have a deadly variant or not. So I think people are asking like whether that would be creating more havoc and they should be, what you can say, more cautious about their lifestyle, or what is thrown in front of us?
Now, okay, I got it. Now there are three parts to this. one part is what that should we concern about the third wave. So we should concern, because this is the novel form. We have not seen this before. This particular culprit, we have not seen this before. We doesn't know. If anyone comes to our locality with a new face, we stare at them. So we should be cautious. And cautious like what? Hand washing, mask, distance, and vaccine. Second is, of course, vaccination. It should be a benchmark that everyone should vaccinate, everyone. And we all have come to know that from last 2 months, already government has declared that a pregnant and lactating woman can also take the vaccines, and there is no effect. And the third part is, we have to build some system in us, all in physiologically and of course spiritually. In physiologically, we have to take all the decisions, like from the early rise at 5 or 6 to see the sun, getting to yoga and exercise, having healthy food, and of course regular vitamin estimation. If any deterioration occur, any type of upper or lower respiratory infection, we should immediate consult doctors and immediate test for at least COVID, so that I can prevent others. And spiritually, all should we be in a mental harmony, so that we can at least gather our strength to stay in one place for 1 hour alone.
That's a great thought, Dr. Day, and we cannot disagree in that. So before I conclude the session, just allow me to share the screen. Here it is. So this is a certificate of appreciation for you, Dr. Day, and we thank you for all the effort and the precious time which you have taken out for this particular webinar, and can't thank you enough for the what you can say, the suggestions which you have given. So from all our side, a million thanks to you, and thanks to all the participants who have participated today. We would just like to apprise all of you that we are coming with another segment of JSS in the coming months. So please stay tuned, and you will be updated through our social media handles. Also, you can please log on to our TIDE website, that is www.tide.in, and you can get all the information on that particular conference, which will be there for 3 days, starting from 1st to 3rd December. So with that note, I would just reiterate what Dr. Day has said, that stay safe and stay calm, and avoid any public spaces, and practice all the social hygiene which has been recommended, and get vaccinated. So thank you, Dr. Day, and thank you to all the participants. Until then, have a nice evening.